Thanks very much, everybody. This is an initiative to help our colleagues get practical, up-to-date information and advice from experts about how to manage their COVID patients, especially cancer and COVID patients. We are going to do this twice a week as long as it is necessary. We are expecting that the Indian second wave, the massive second wave, is going to go on for quite a while, and therefore we are ready to do this as long as there is a need for it. So we are going to be flexible about it. Next slide, please. So somebody in the morning was asking who's an expert. So I'm not an expert on COVID, but I'm definitely having a lot of experience on how to conduct virtual academic activities which are meaningful and useful. Next slide. So this is one of the real problems that the pandemic is causing, and that is that healthcare professionals and doctors are actually dying of this infection all across the world. And I'm sure that the official figures of 573 in India are, this is of course July data, are way less than actual deaths that our colleagues have suffered. Next slide. On 4th April, India became the number one for having the largest number of daily new cases, and it overtook USA and Brazil, as all of us know. Next. But the real important thing is that Brazil and US, when they were overtaken by India, were having a plateau or it was going down. But the Indian graph of number of new patients added every day has been just going up and up and up. Next slide. So it's not surprising that the first peak we had 93,000 new cases on September 17, but on April 18 we already had 3 times that. That is 2,19,000 new cases. Next slide. And this is the sort of distribution on the right of where is the largest number of patients, and Maharashtra is of course having the dubious distinction of being in the lead. And the way, one of the reasons that we ways of circumventing or dealing with it is to give vaccines. And 124 million doses have been given in India, and hopefully more and more people will be vaccinated in the coming time. Next. Now, why is vaccination is important? This is what has been published recently from CDC USA, that the vaccination protects against all infection in 99.99% of patients. It protects against serious COVID infection in 99.999, and it protects against death from COVID-19 in 99.9999. Having said that, next slide. We are now having a problem of mutations, and I'm sure that all of you will be discussing and answering that. The SARS-2 with a 30 base RNA genome has 2 single letter mutations in a month. So it is not surprising that such mutations occur. It is actually half the rate for mutations in influenza and 1/4 of the rate for mutations in the HIV virus. Next slide. But there are certain mutations which are really cause for concern for us. For instance, the N501Y mutation, which replaces the 501 amino acid asparagine with tyrosine. And the problem is when it affects the spike protein, which is the receptor binding domain, as shown here. Next. So this is an evolutionary edge for the virus. Next. And this is how the mutated viruses are being spread. So if you look at the top left-hand side, you can see the D614 mutation in India, which is a small dot. On the top right-hand side, you see that the dot now becomes bigger, and it is a combination of blue and white. So we have a different mutation. And now if you see at the bottom right, you see the large number of blue mutation patients that we are seeing in India. And this is something dynamically changing every second. Next slide. So is this happening in India today? And this is assuming that the community is using mask and social distancing on a regular basis. So what happened is, if there is a first case of B117, that is a UK variant mutation, it will be one case as opposed to 1,000 other cases. And very quickly, by day 63, it is almost half the cases. And if this is how it happens, then naturally the mutated higher virulent virus is going to take over in the community. Next slide. So, with this background, mutation, infectivity, and immunity is something that is a cause of concern, and everybody, whether it's an expert or a layperson, keeps talking about this. Next slide. So, with this preliminary context setting, I now hand over to our moderator, Dr. Sahoo, and Dr. Amish Vora to take this further. Over to you, sir.
Thank you, sir. It's such a wonderful information, but scary also. The last 3-4 slides about the mutation. Can I have the next slide, please? So we are going to present 1 or 2 cases depending on the time. I will start with my first case. This is a 56-year-old female diagnosed with acute lymphoblastic leukemia, Philadelphia chromosome negative, normal cytogenetics, what earlier we used to call CD10 positive, CALA positive ALL. Patient was counseled and started on BFM 90 protocol. Everything went fine. This patient has been, she has taken 1 dose of Covishield around 10 days before diagnosis. She went on to receive chemotherapy without any issue. Day 21 of induction, the CBC did not show any blast, but there was absolute neutrophil count, which is less than 600. During this time, daughter became COVID positive. So our first question, which came to my mind and I think everybody, is when should we test her? Dr. Sahoo.
Yeah, thank you, Dr.
How
Amish.
you have to unmute.
Yeah. So I can come down to the first thing, and before that, let me introduce the panel. Also, we have clinicians, microbiologists like Dr. Mukul Acharya from UK, we have Dr. Nandita, who's an intensivist, who has worked through the whole COVID thing in UK, and we have lovely. They can share the experiences and answer questions. We have Dr. Tanvi and Dr. Ravi and Dr. Chetan from India across the country, and Dr. Tanvi has good experience with plasma therapies. That's what it is all about. So now jumping to the things in question. So this patient, Dr. Mukul, I would like to ask you, because what we normally see, can we come to the slides, please? What we normally see in the scenario is when the patient gets positive, suddenly I see the government jumping into and testing the contacts. So where do you feel which is the best time to do a contact tracing, and when should we be doing a RT-PCR for the contacts? Is it as soon as the report comes with the first member to be positive, or there's a particular way how we should go ahead? Can we have that first?
Okay, thank you, Dr. Sao. I think what happens here is the protocol which we follow here in the UK is, for example, if you have a patient who's going to be started on some form of immunosuppression or some form of systemic anti-cancer therapy, SAC, as we call it here, what is most important is if there is a time, meaning if you can afford to wait for a few weeks before starting the immunosuppression or the chemotherapy, then you need to try and vaccinate the patient first, and that is the first protocol that we follow. But if the patient is really unwell, which means the cancer is quite advanced, and you feel that the patient has to start chemotherapy within a week, we would still recommend giving vaccine. But the only thing is you should not give vaccine.
Can I come in, Dr. Mukul? My point here is for the contact tracing.
No. I'll tell you why I'm saying that.
Yeah,
Okay, fine. So as far as contact tracing is concerned, when to test and what sample? See, ideally, now can we go back to the previous slide to see what happened on day 1? Yeah, so day 1 induction, so the daughter became COVID positive. So I assume that the patient is staying
on day 21
with the daughter. Yeah?
Day 21, third week, not day 1.
Yeah, third week. Yeah. So the daughter was tested positive. So your question is, when should we test the patient? Is that correct?
Yeah. The contact of the patient, of anyone who's COVID positive.
Okay, so basically, so I'm assuming that the patient is staying with the daughter. They are in the same household, correct?
Yeah.
Right. So if the daughter is become COVID positive, the normal incubation period for COVID-19, as you all know, is from day 3 to day 14. okay, where during which time the patient can develop symptoms and become COVID-19 positive. But someone who's immunosuppressed, I would have thought the incubation period would be actually much shorter and the patient can become symptomatic quite soon. So if the daughter has become COVID positive, I'll probably one is test the patient, and I would do serial testing for the patient. So I would start testing the patient say from day 4, which is like you give 3 days for the incubation period. I would start testing the patient from day 4, and I would do that practically every third day. That is what we do here. A. B is
Okay. Okay.
I would test all the other family members who are staying in the same household under the same roof with the patient and with the daughter.
Okay. So, Dr. Mukul, we hold you here and we'll come back to this because this is an important point which I want to point forward. The next slide, please. Dr. Chetan, with your experience and vast experience, what do we do it? Because I have seen this sometimes, and that could be reason why we missed a lot of positives on contact. Is it that we have waited for the contact tracing? This is very important for us to keep a control on this COVID, because if you test the contacts too soon, as it was told, we would be missing out and we will be getting a lot of negative RT-PCRs. So Dr. Chetan, what's your experience? And then we jump to the question with sample.
Right. What I would do is on day 5 after the first contact, I would test on day 5. Okay. So generally, as Dr. Mukul has already said, the incubation period is between 3 to 14 days. But day 5 sometimes seems to be the sweet spot where you can test. And if that test is positive at that time, then of course you have your answer. If it is negative, as Dr. Mukul Acharya said, I would test after 3 days, or maybe the patient becomes symptomatic, and there you have your answer. But most of the time, your current variant that is more prevalent, the entire family will be positive over a period of time.
Okay, that's in cancer patients, as Dr. Mukul told, Dr. Ravi, or the incubation period is shorter, they become positive much earlier.
So it is difficult to say, because generally we see the patients right when they have presented to us. So it is contact tracing in our setting becomes very difficult to say that when the patient became positive, when the patient was exposed, because by the time the contact turns positive or the index case turns positive, the patient has been staying with the patient. The patient has been exposed 2 days prior to that
for quite some time. Can you come to the next slide, please?
Yeah.
I think I got a point. So
the 5 is pretty good.
Yeah. So the sample thing, I'll go in very fast. That nasopharynx and throat swabs both have been tested to be equally effective, and that is how the Indian testing has changed. Also, we see the pictures of both the things going on, and testing goes both ways. This is equally effective for both to pick up the positivities. Next slide, please. Yeah, this is what people were speaking about, and if you look at it, the curve. That is where the 5th day. Why I brought this up? This is a common knowledge, but what I have seen in my part of the country, of the state, where I practice is the contact tracing from the government side. I don't know, nowadays it has been less now emphasized, but in the initial first wave, it used to be quick. The day the patient comes positive, that is the day when the samples used to be collected, and that is why I usually feel that the contact positivity rate was quite low, because we probably were picking up and most of them were not retested. Dr. Amish, your experience in Delhi, because this is what I used to see in Madhya Pradesh, the day positive patient, that is the day when the sample is picked up from the family members, then never retested. So what is your experience, Dr. Amish?
I completely agree with what Dr. Chetan has said, and I have written that in the chat box. This wave, crystal clear. If one family member is positive, irrespective whether tested now or after 3 days, sooner or later, almost 99% of family members are becoming positive.
That's true.
This is time and again I have seen in last 20 days.
Yeah, but what I mean to emphasize is we should be testing on the day 5 of the symptoms is something that is the maximum time when you'll be really getting those tests. Day 3 to day 8 or 10 is the maximum period, but day 5 onwards is where you really get a positivity. So someone whom you have tested earlier, negative, you should emphasize on the repeated testing, as Dr. Mukul told, but very rarely we test beyond 2 times. But he very clearly told in UK they have been testing every 3 days for next till second week. And that is very rarely we do. That's something I think it will give us more of contact positives. So
No,
any
Sahoo,
thoughts?
Sahoo.
This patient,
Sanket and Sirish Alulkar have asked a question which you have partly answered. The question was, day 0 is start of symptom or start of RT-PCR positivity?
Sir, this day 0 is merely the symptoms what we are asking for.
Symptoms.
Symptoms. Yeah, symptoms.
Correct.
Symptoms and
So
day, that would be the day of contact.
Yeah.
That would be the first day.
So
Perfect.
Next slide.
Okay.
If you go to Tarini.
Next slide. Next slide.
Yeah. So this patient, Tarini, as Dr. Mukul said, same day as daughter came negative. But we were not convinced because she was on heavy dose of steroids, 100 milligram of isolone as induction for ALL. We repeated after 3 days, and that came to COVID value positive, and her CT value, cycle threshold value, is 27. This is a topic of discussion in case, Tarini, you want to do it. But going forward, asymptomatic patient, saturation on the day of diagnosis 99%, 6 minutes walk test, again saturation 98%, pulse 72 per minute, no fever, cough, running nose, breathlessness. Question was ALL patient day 24 of induction now.
Let's ask Dr. Ravi.
Yeah. What should we do now?
Dr. Ravi, in your practice, would you admit this patient? No fever, asymptomatic. Would you admit this patient?
Yes, sir. We'll admit the patient because on steroids, generally, the symptoms won't be there. So we'd like to monitor for the next 2-3 days.
So you will admit this patient. Dr.
Yes,
Tanvi, what has been your practice? Do you admit this patient?
So, sir, since patient is asymptomatic and saturation is holding at 98% even after a 6-minute walk test, not showing any symptoms of breathlessness or fever at the moment, generally we have advised our patients to monitor at home itself, and we are in constant touch with them. We've had patients of ALL who were tested positive. In this scenario, we've advised home monitoring and constant touch with the patient.
Dr. Nandita, in UK, a immunocompromised patient, ALL on the induction, what would you do? The counts are little on the lower part side of it, but afebrile and doing well.
If they're afebrile and doing well, as Dr. Tanvi said, they would be keeping a, they would ask, we would ask them to keep a close eye at home.
Okay, so that's how, and you closely follow them up. Dr. Chetan, any different in TMH?
TMH generally ALL inductions we were admitting, but now with the shortage of beds, we are monitoring them closely if they have facility for home isolation.
So this is a patient whom you would probably go for home isolation.
Yes, in the current scenario with the shortage of beds.
Okay, otherwise you would have just...
yes, otherwise we would have admitted.
Okay, so what we are getting here, what we are really getting the picture here is a little bit of divergence in the outside, because it's the policy they don't admit, but India, we agree that these could be home isolated, but most of us feel comfortable to admit the patient because of the lower neutrophilic count. Okay, fine. So next slide. Dr. Amish had few more questions on this part. Next one.
So before we go to the Neha, so this was one of my main question. Whatever little we have understood of COVID management, steroids to be given in moderate patients, and that also little later in the course. So maybe, Tarini, with your permission, if you can ask this question to our experts and you can forward. Should we stop steroids in this patient?
No, rather than that, should we tell that because you are already on a steroid of 40 to 60 milligram per meter square, a good amount of Visolon probably at around 80-100 milligrams. So the question which Dr. Vora wants to ask is, would any one of you managing, let's start with Tanvi, would you alter the steroid or stop the steroid? Very unlikely most of us would not stop it. There's 21 days sudden stoppage of steroids, none of us will do it. But would you just try to bring it down faster than usual, Dr. Tanvi?
No, sir. In this scenario, considering the patient is already on steroid, I would give it the benefit of continuation of steroids.
So continue the ALL as protocol and not do anything to that.
Yes.
Okay. Dr. Chetan and Dr. Ravi. Dr. Ravi first.
Yes, sir, I agree, because we have seen that steroids are a part of treatment in COVID.
But the dose is very less, 6 milligrams. And the second thing is what we need the steroids is for a lung involvement and severe disease of the COVID. So that's where actually Dr. Amish wanted to point this out.
Yeah.
Not
The
sure.
idea of giving steroids later, what we understood was that if you don't give steroid early on, the body's immunity will fight against COVID virus. That was the idea of. See, I'll tell you what I did for this patient, but would like to understand from people. So what I am getting, Tarini, that everybody would want to continue steroids.
No, let me ask Dr. Mukul and Dr. Nanda. Let's have the view across that globe also. Please, Dr. Nanita first and Dr. Mukul then. What would you do this? What would you advise?
I would continue like what Dr. Tanvi said, because I'd give them.
You would continue same dose.
Yeah.
Dr. Mukul, any difference of thought?
Right. Okay. So I know the steroid dose is quite high, but if it is an essential part of the chemical separation or the chemotherapy, then yes, I would not obviously interfere with the treatment for treating the cancer, as long as the patient remains asymptomatic. More than that, the saturations which you need to monitor on a regular basis, and some more sort of counts, which will obviously we can come to that later. What are the counts that we look at? If that is fine, I would not interfere with that. No, I would.
You would continue. Okay,
yes.
Dr. Amish, I feel the general consensus is because it's a part of the protocol, steroids would be continued at what it is. They would not alter it for a normal patient who is not a cancer patient, where steroid is not a part of the protocol. That's what the impression is coming. Okay. So a very burning question brought out by a lot of panelists who are just viewing us is: would you consider chemotherapy continuation with cytotoxic, or would you alter and try to give something which is non-hematotoxic, maybe L-asparaginase could be continued? We'll come to this question. Can Dr. Chetan, you answer this? What protocol of ALL would you take away on a COVID positive patient of such type who's asymptomatic, or what would you still continue apart from steroids?
Right. So I can speak mostly about my experience in pediatrics.
Please.
We have not interrupted therapy for patients who are on induction or intensive chemotherapy. But in case we feel the patient becomes symptomatic, we would withhold the high dose chemotherapy and continue on maintenance sort of chemotherapy for these patients. If the patient is a solid tumor patient who can defer treatment and it's not urgent to maintain the intensity of the protocol, I would wait till about 5 to 7 days, when you know that by between day 5 to 9 you would get worse. If the patient remains asymptomatic during that time, I would resume.
So basically, in the pediatric leukemias, you tell that you will continue with your donomycins as is because it is very important for us to get the remission. That's the idea we are getting. In the mildly symptomatic, in spite of being COVID positive.
Correct. Mildly symptomatic, I would withhold the donomycin.
Okay. So you will be told, or
one question. Akshay Shivchand has written a question. I have 2 patients of Hodgkin's disease who came positive today, both having running nose and sore throat. Both are having low counts. At present, kept under observation at home. Is that a fair decision?
So anyone in the panel could take it?
I would second that decision. I agree.
Yeah. So that's what we discussed. Actually, the panel discussed that if there is nothing that warrants admission at this point of time, they would write home isolate, look at the saturation. If there's any deterioration or anything, then admit the patient. I think that answers that question, sir.
Yes.
I think that's it. Yeah. So basically, I have a little thing what Dr. Chetan told. What I got it, if I'm right, he can tell me yes, and move to other panel. That in an induction of a leukemia, he would still, in an asymptomatic patient, if it's COVID positive, would continue with the chemotherapy as per schedule, and only stop it for those who are moderate to severe. That's what it is. Dr. Chetan, yes, I'm right. I got that thing right from you.
Yes, but I would like to ask, why was the patient tested? Generally, this is very hypothetical situation.
Because this is not. The contact was positive. That's what it was.
Okay.
That's what.
And I would continue.
Yeah. So okay. So Dr. Tanvi and Dr. Ravi, would you continue chemotherapy? Because that's what we are told, that once the patient is COVID positive, we do not give anything that is myelosuppressive or potential, like donomycin should be avoided. Would you do that? Or would you give the protocol as such? Dr. Ravi first.
Yeah, generally in our practice we avoid cytotoxic drugs, sir.
Okay, so you are avoid cytotoxic. Dr. Tanvi?
Similar, sir. So in if it's an induction protocol, if we're in the phase of the induction, we are on the side of withholding because we're worried about the counts and infection flaring up. But we do have a patient on maintenance and similar situation where the family member had tested positive, and hence we did test for the patient in turn. We have withheld the maintenance for the time being.
Okay, so basically the gross opinion, but Dr. Sweta Bansal is there. I see her on the chat. If she does a lot of leukemia, I saw Prashant commenting that he would not give donomycin. That's the overwhelming thing. Dr. Sweta, do you also would agree that we should be stopping donomycin and cytotoxic and just continue VCR? The L-aspergillus, I'll come to this after this. Just a quick one, if you can unmute and yeah, okay. She also feels the same. So basically, except for Dr. Chetan, most of us believe that we will not be giving anything that is cytotoxic. Dr. Amish had a very...
Shweta had another question.
Yeah.
Is there any data or experience which says Lunase increases thrombosis in ALL patients with COVID?
I was coming to that because Amish had a bit question also. So L-aspergillus and ALL and COVID. So would you stop ALL with L-aspergillus for the time being till 14-15 days because of this? Or would you continue? Dr. Mukul, what is the practice? I don't know how many leukemia patients you are looking at there. Starting with you, and if Dr. Nandita can come in, and then I'll go to the Indian experts. Sorry.
Okay, so can you sort of repeat the question for me?
Yeah, please.
Go on. Yeah.
Yeah. The question was, L-aspergillus does produce a good amount of thrombosis, and there is an issue with the thrombosis in the CNS area. We find a lot of some. So, is there a concern with COVID? Do we withhold, or do we continue?
To be honest, what we would do is at that time is look at the stage of COVID. So let's assume that the patient is in the hospital. Okay. With me for whatever reason, the patient is on treatment. If the cancer is really overwhelming, if the cancer is really a very advanced stage, and where you cannot compromise with the treatment, then I would not stop that, but we would keep a very close vigil on the patient's other parameters. So that includes things like D-dimers, serum fibrinogen, doing the entire coagulation screen. And if required, trying to use sort of low molecular weight heparin if it comes to that. But I'm sure Dr. Nandita would be sort of more adept at that. But
leukemias with thrombocytopenia, all of us will be very skeptical about the low molecular weight. Although I know
exactly. But then I would not sort of compromise with the therapy. I would just keep a close eye. And if the patient was to become breathless, then you have you have the option of doing investigations, doing a CTPA to make sure that that there is no.
Dr. Nandita, with your ICU practice or with your colleague discussion with the oncologist, do you think that L-aspergillus is a drug which we should avoid?
What we do, and I have to be very frank here, is we liaise with our hematologists, and if it is a proper advice and discussion with the hematologist, because we do not have as many leukemia patients in our critical care. So that is an advice given by them. So we take it from them itself. So.
Okay, I agree. Dr. Chetan, I feel for you, L-aspergillus continue.
Yeah, so pediatric patients, we would continue. If the patient is 10 years of age, then the risk is higher. So in that case, I would hold.
Okay, so the overwhelming the discussion that's in the chat is people would like to hold it because some feel that it can be compensated. The L-aspergillus dose can be compensated after 2 weeks, and you can easily schedule the dose. So, Dr. Amish, anything you want to add to this question of L-aspergillus?
So I'll just share. I discussed with many people. In fact, I discussed with Dr. Manju also, and she said that they continue in adult, especially 50 years and above, only VCR and steroids. They hold on with L-asparagines and daunorubicin. That is what she told me, and I also read in few of the international guidelines the same. The bottom line in this patient,
50 or
the bottom line in this patient, Tarini and everybody else, what happened is there are no beds for admission in Delhi. There are just no beds.
Mhm.
So I didn't know. I explained to patient that I can admit you in some COVID facility and continue with VCR. Patient flatly refused, "Ke, sir, 5-7 days I'm not going out anywhere." I have documented that, and that is a practical issue which I face with this patient. But it is good to have
Okay,
a
agreed.
topic here.
Okay, no problem. So the consensus that comes in majorly, although we have a little bit of issues with the pediatric and the adult, but majorly most of the people want to withhold elastogen. Weekly vincristine is a choice. Steroid goes on. That's what the overwhelming majority was. The donomycin is definitely a big no for majority, nearly except for one or two. Most of them want to stop it. So that's where we stop on this part of it. So now coming to the antiviral, yeah.
Basically, for patient who has turned COVID positive, generally we wait for 5 to 7 days. So this patient that we were discussing is day 24. So generally we would wait for 5 to 7 days before giving the donomycin. So if, as I said earlier, that if the patient becomes symptomatic within that 5 to 7 days window, we would hold. Otherwise, if the patient remains asymptomatic within the 7-day window period, we would continue the donomycin. It is not that
you would not.
I would not hold, but I would wait for those 5 to 7 days once the patient has turned positive. But I would continue the intensive therapy.
The most burning question about we will have remdesivir, the magic bullet, little on the next slide. The favipiravir or a faviclu, which is a trade name for one of the drugs. We just go on next. Go on. Just let's start with antivirals. Dr. Nandita, in which patients in UK do you give remdesivir? Let's first start with remdesivir. Is it the magic bullet? We have brought this up very importantly because in India there is black marketing, there is shortage. Every patient of COVID is being advised remdesivir. What do you do in UK?
So it is slowly the use of remdesivir in UK is reducing, especially if patient comes to. It's shown that there is a reduction in the length of stay, but there is not much difference in the mortality rates. Is that, and correct me if I'm wrong, and therefore in critical care.
Sure.
So in the wards, and I've spoken to the others because I mainly deal with the critical care side of it. Once they come to critical care, we usually don't give remdesivir. But in the wards, yes, people who have got their oxygen requirements have got increased, and they go on to NIV or high flow nasal oxygen. People have been giving that, but again, the jury is out on it. If they come to our critical care and receive high flow nasal oxygen and all that, they may not receive it. In fact, I have not given remdesivir.
So you don't give it for the patients. Okay, you don't give it for patients or high flow oxygen
or for sure. Yeah, sorry, not in critical care.
So or for patients who are ventilated. So that's basically.
Yeah, no, not for ventilated or like those who are on high oxygen. Yeah, we are not giving it. But
so Dr. Mukul, what is your experience? Is it the same as Dr. Nandita told or something?
Well, I mean,
and who is the ideal patient for remdesivir?
Yeah, okay. So most of us here, when it comes to the use of antiviral, especially like remdesivir, we've basically followed two trials. One is the biggest trial to date, what we call as the WHO Solidarity Trial, which had almost 11,266 patients in 405 hospitals across 30 different countries. And the trial concluded that none of the 4 drugs which were studied in the trial, which includes, drugs like hydroxychloroquine and ivermectin and remdesivir, did have any measurable benefit when it comes to the mortality or the disease scores. That was the first trial. The second trial has been recently concluded in the US, which is called as the ACT-2 trial. So it's ACTT, which means Adaptive COVID-19 Treatment Trial, which was coordinated by San Antonio in Texas and across 30 different hospitals. They found that patients who are on high flow nasal oxygen, or receiving breathing with a mask, had a recovery time of slightly short, 10 days as compared to those not on remdesivir. But there is the caveat here. It was not remdesivir alone. They were using baricitinib. You see, so remdesivir along with baricitinib when used in these patients who require high flow nasal oxygen, had a slightly reduced hospitalization time, which was 10 days as compared to 18 days when patients were on remdesivir with a placebo. So remdesivir on its own has not really been shown to cause any change in mortality.
So basically what I get out from both of you is, what I really get from both of you is that it is not the magic bullet as it has been projected here.
Absolutely.
Dr. Tanvi, I start with you. What do you feel? Why is the hype here? What's happening? And do you use, have you used remdesivir?
Right, sir. So I would like to say that remdesivir, when it had been introduced into the market, it was definitely getting used for the more severely ill patients with severe COVID, and that was the general practice was. As the data evolved, and what we realized is that the usage has moved more towards moderately ill COVID patients, because the general thinking is if we use it within the first 7 days of hospitalization of these patients, especially who are dyspneic and have higher respiratory rates and have saturation less than 94%, thereby on oxygen support, this subset of patient tends to benefit more and probably reduces the chance of shifting to ICU and progression to more severe COVID. So definitely in our setting, we have moved what we have witnessed is the treatment option has moved to the setting of moderately ill rather than severely ill COVID patients.
Okay. Dr. Chetan, in your practice, although pediatric, the approval is come through, although the trials do not have it, you can use it beyond 3.5 kg. Where have you used it in your patients in a pediatric age group?
Yeah, so in the early phase, early part of the first wave, we had tried to use it, and we generally used it in the sicker patients, but we did not find it to be very effective.
Okay.
So we have stopped.
So that's what it is. Okay. So which, Dr. Ravi, any thoughts?
Yes, sir. I deal mainly with the adult patients, and basically it depends on the personal experience. And personally, we are convinced that whenever there is desaturation, remdesivir has helped in the recovery.
Can I ask you, Dr. Ravi, what has been, because you use 10 drugs, so what made you feel that remdesivir is the drug that has made the difference?
That's what, sir. It's only a personal experience.
Okay. Point well taken. So I think the chat box is silent because I think people are either very much convinced about remdesivir or they're not at all convinced about the remdesivir. So that's one of the reasons which I can put. I will ask Dr. Amish question on the Janus kinase inhibitors. There's data on that. Dr. Amish, asking you, the brainchild of the CME. Where do you feel is that we should be? Because I will come to the next slide, which will have the data.
I think all the trials which are done, like for example, what Dr. Mukul said the last about the COVID treatment, ACTT trial. I think remdesivir has, according to as Dr. Ravi said, some role which every pulmonologist treating COVID will tell you in India. We looking at the trial right now when the disease, the second wave is just 1 month old, is too early for us to say yes or no for it. I think there is a space for it. We need to identify that space and not madly rush after it. But we can't discard it also. It's too soon for us to do that.
Okay, I'll come to where the real advantage is there as per the trial. But if you look at into the remdesivir with the Janus kinase, there is data evolving. But I don't think there's any hardcore data to tell that definitely there is an advantage. Is it where we stop on that, Dr. Amish, or you want to add something?
No, so the first wave, many of my relatives were admitted in Bombay and Hiranandani Hospital. If anybody's from Hiranandani Hospital here, they had almost 12 to 14 patients on ibrutinib in severe COVID. And they found that these patients did quite well. So if anybody from Hiranandani, and if they want to share their experience, because this Dr. Ashish Bakshi also told me the same thing. And Tarini, there you go in the chat box. The question what we were discussing has come up. You have to unmute yourself, Tarini. You have to unmute yourself.
So while we are waiting, there's a question.
So you told me yesterday.
Go ahead. Sorry.
Because remdesivir, I'll answer what the evidence is. A lot of the things have been spoken. I agree to most of it. I do not agree to some of it. But favipiravir, Amish, you told me that you really spoke to people, and all of them advised for your patient who is symptomatic to start favipiravir. So that was what the advice is. Dr. Mukul, the only evidence I could find for this drug is it decreases the viral load, it decreases replication, but like all antiviral, there is no big hardcore data. Even the government approves of this as to be used. Do you think it should be used on routine without a level 1 evidence?
No, sorry. I mean, I would not use it routinely. Definitely not. You see, because the other thing is when you use a drug, when you are not sort of very confident about its effect, especially when it comes to mortality, when it comes to reducing the hospitalization time. The other thing you have to look at is the side effects. And we found a lot of these patients would have problems with their renal function. And that then becomes a headache to manage. So you have to really decide that is the advantages of using this particular antiviral drug can offset the side effects, especially the renal side effects. If the answer is yes, then fine.
So basically, then you can. Okay, so basically that was a chat, I think so that was answered in the medical oncology chat group which you have separately by Prashant. He looked at this as a uric acid level which increases on day 5, day 6, and he also spoke about the renal functions. So favipiravir, as I get the evidence, even the Infection Control Disease Act US does not recommend it as a use, but people use it, and a lot of government agencies across the world have advocated the use of it. But the take-home message is there is no level 1 evidence to recommend its use. So, Dr. Amish, any words on this before we move on to the next? And Dr. Tanvi, what is your take on favipiravir? You use it, or you feel you use it just because you need to add antiviral and it's an oral drug? That's it. That's it.
Honestly, sir, I do not use it.
Okay,
honestly,
you do not.
I do not use it, and I don't see a point in using it. That's just my opinion.
Dr. Ravi, you use it or not? Don't use it?
No, sir. Nowadays we have shifted to doxy and
you used remdesivir. You should be using this, yeah. Dr. Chetan, what's your take on? Yeah, what a take on? Maybe you're not the age group which you see, but do you think it should be used?
So when I was rounding on the adult patients in the COVID ward, I felt that it brings down the symptoms drastically, but does it reduce mortality as such is the question. So anyway, I think the patients would have gotten better after a few days. So it is very difficult to really say whether this drug is effective or not.
Dr. Amish, you wanted to say something? Yeah.
No, I said let's move on. I think verdict is still open on remdesivir, according to me. It is not closed.
Okay. So basically, I'll quickly move
Sahoo,
on.
I just wanted to ask the other panelists.
Tell me, Roshni. Yeah.
Yeah. See, when your patient is on outpatient basis, you have a COVID PCR positive because your contacts have developed COVID. Are you going to withhold favipiravir or not? We don't have beds. We have oxygen shortage. So are we going to use the drug or not? That is the question. And that question needs to be very clearly answered.
Do you want me to take that question?
Please.
Thank you. Sorry. So who is it? Is it Dr. Pandey? Is it Dr. Roshni?
Dr. Roshni Pandey. Yeah.
Hi, Dr.
From Jabalpur.
Mukulacharya. Okay. You see, when it comes to using favipiravir, and I can tell you, favipiravir drug, some cases of influenza where acyclovir, where drugs like Tamiflu would not work. They just extrapolated that data and thought that, oh, right, it might prevent the virus from multiplying. There is only 1 or 2 small studies which have come out of Iran and I think Japan, which says that favipiravir will probably benefit. But if you look at much bigger random RCT trials, double-blind random control trials coming out of Hungary, coming out of UK, they have very clearly defined that favipiravir is generally has no significance whatsoever in the symptom progression or worsening or in any form of way. In fact, I know so many of my relatives in India who've been prescribed favipiravir the moment they were COVID positive. Their one single common complaint was loss of appetite, which was not a part of COVID. COVID will give rise to loss of sense of taste and smell, but not loss of appetite. They were so badly anorexic that they ended up not eating and having been given IV fluids. So why use a drug which is causing...
Okay, so basically the jury is still out. We do not have level 1 evidence for favipiravir. That's what is the take-home thing. We've used it because we feel that something works. The best evidence that has come from favipiravir. Next slide, please. I'll come to that in a minute. Yeah, this is it. It is approved in some countries, including India. The government of India approved it. That's for sure. The Glenmark trial is still not out. I did not look at I could not find results of the trial. The favipiravir has shown a rapid viral clearance. That's for sure. It is significantly important rapid viral clearance that was seen on day 5 to day 7. But most important is the other parameters as we look out for remdesivir was not addressed. That is what the experts are telling. So that is why it has not been recommended in major countries, and major FDAs have not approved it for COVID use as such routinely. Next. I think, Roshni, that answers your question.
Sorry, Dr. Sahoo, can I interrupt? Which study was that which showed rapid clearance of viral clearance?
I will send you. It is published.
Maybe later because
I'll send you. There is a 25% reduction in the viral clearance, and which was statistically significant. That is very clear.
But then was it a RCT which combined using a placebo against favipiravir? No. So if you had left the patient alone, the virus would have still anyway cleared for a mild disease. So I will not subscribe to that.
So what I think is, I'm closing, both of us are the same. I also don't practice it. And I'm telling that people do it thinking that we need to go for antiviral. We go down to here. The adaptive, the trial which people were speaking about for remdesivir. Next.
Sahoo, before you proceed, Dr. Gautam Makadia has asked a question about chemotherapy. So I will read it out. What if patient is in phase 2 induction of ALL or a patient of chemotherapy Hodgkin's lymphoma and due for third cycle of ABVD, and now the patient develops mild COVID? Should we wait for the recovery for 14 days or should we continue chemotherapy with a close follow-up?
I think, sir, the question was answered that all of us felt that chemotherapy should be deferred at least for RT-PCR clearance, and at least all of us feel that 2 to 3 weeks is the time period. I think if any panel disagrees, he can come in, otherwise we move on.
And
I think that question was answered.
CML on imatinib, will it be the same?
Imatinib, I don't think we stop it. I don't stop it. Is there any data I would like to see? But I think I continue on imatinib.
Okay.
Prashant disagrees.
So Prashant, I disagree.
Prashant.
So you said that you have to wait for. So should I speak? Should I speak?
Yeah, please, Prashant.
Yeah. So I disagree with with what you said, that you are going to wait for 2 to 3 weeks for PCR clearance, and I don't think that would be a good idea for curative settings. I think around 8th to 10th day of infection, most people would, if they have to worsen, they generally do worsen. And if you have waited for 7-8 days, the patient is stable, all the inflammatory biomarkers are normal, and the patient is stable. For a curative setting, you can safely resume chemotherapy. Waiting for PCR means that there would be a subset of patients which would not clear the PCR even at 3 months or even at 4 months. Then what are you going to do for that set of patients? So we can't rely on PCR clearance. It has to be symptom based.
So symptom based 2 weeks is what it is.
And inflammatory biomarkers.
Yeah, Dr. Chetan also disagreed on that, and he also, I think, he's speaking the same thing as Prashant told. Is it okay, Chetan?
Yes, same thing, but for pediatrics, we have started with 14 days waiting period in the beginning and shortened it to 7 days. If by 7 days, we will continue.
Can I ask something? Is there any guideline that has come up for any cancer group regarding time period? Because the last guideline which I saw, not a guideline, most experts spoke about clearance. Is there anything that has come out in between both of you? Can you answer shortly, and then we move on? Dr. Chetan?
It is our experience. I have not seen any guideline that.
So basically, it's experience based. Dr. Prashant, any guideline?
So ASH still makes it 2 weeks, but not PCR clearance. 2 weeks.
So 2 weeks is what we
symptom resolution and stable.
So the take-home message what we're coming through is as per ASH, but most of the guidelines have been silent about it. Dr. Amish, we have 10 minutes left. I'll complete that. So what I meant was that that is where it is. 2 weeks is a comfortable time for us for asymptomatic patients. So I think that's where we conclude. Lesser than that, it would be your choice and a discussion between you and the patient. That's where it is. Next.
Sir, can I ask a question here?
Yeah, please. I'll complete this. Then we can. The interpretation is what people told. This is very important because remdesivir question has to be answered. In severe, the remdesivir reduced time to clinical recovery after the adaptive trial. If you look at it, if you subset analysis, there was no observed benefit in high flow oxygen. Ventilated patient, ECMO patient, it was not, because you're not powered to look into that. But the maximum benefit was there where you had augmented oxygen just on oxygen support. The patients who are moderately probably sick, but severe patients who are just on oxygen support. That's probably the best patient who would act on a remdesivir. But you should start it early, probably within 6 to 8 days of the symptom control onset. Later, remdesivir really does not act. Next. The Solidarity trial was a negative trial, as was spoken. I'll just skip that. Next. So take home for remdesivir, all trials have one thing in common. As Dr. Nanda told, they do not make a significant difference in mortality. Solidarity, the biggest randomized trial, 2,000 patients odd in the remdesivir, was a negative trial. Does not benefit if given late. Does not benefit if ventilated and those on high flow oxygen. Next. The best candidate would be patients with moderate, severe on oxygen supplementation and started little bit within day 8. Next. Others, next. Dr. Prashant told, if not favipiravir, then why others? Yes, it is not recommended even for the lopanavir and the ritonavir. Ivermectin, the IDC spoke about the inadequate evidence. They did not speak about pro or against ivermectin. They feel that there is no big evidence. Chloroquine not recommended. So I feel, Prashant, we have answered this. All of us use it, but we use it just thinking it will work. There is no high level evidence for that. Next. So this, Dr. Amir.
Yes. So day 6 of, that is yesterday, of COVID infection, patient developed fever of 100.6, later on 100, then again came down, and in the night again 100.5. Today morning, inflammatory markers were sent, and while we were talking, I got the report. This patient CRP is 125. That is today's report. So day 6 of positivity, Tarini, fever, low grade fever, and CRP of 125. Now what?
Chest involvement, Dr. Amish. People would like to know the CT scan or X-ray. Something chest is involved.
I did a video call before on this webinar, and 6 minutes, in fact 10 minutes walk test, saturation is 98%. I have not done the CT scan because patient is not having even iota of cough or breathlessness or drop in saturation. I don't think it's advisable to do CT scan at this point of time.
So your CRP is high. That's what you told. And your IL-6 is there. You have sent the IL-6 also?
IL-6 is 26. Ferritin is borderline high.
D-dimer?
D-dimer is a little bit of high. Not very high. I don't exactly recollect the value while you ask questions.
Okay. Okay. Can you have the next slide, please? Next, please. Okay. So this is a very important thing. I feel, are we over-investigating our patients? Dr. Mukul first. The minimum investigation. Dr. Amish did a CBC, LFT, RFT. I assume he has done a random blood sugar. All of us do. A C-reactive protein is done. LDH is done. The D-dimer is done. IL-6 is done. And the C, that's what it is. I think that's what the base thing is. Do you feel these are the minimum investigations you would also advocate? And how frequently? I've done it on a day 0, maybe day or diagnosis of RT-PCR positivity. If the patient is asymptomatic, do I need to have a repeat investigation at day 10? Or let's say, or if the patient is okay, I don't do it at all.
Okay, so I believe we are discussing a patient who's an oncology patient. Okay, we're not discussing the patient. Yeah,
sure.
Okay. So obviously, so when it comes to an oncology patient, I obviously would have a very low threshold for these investigations and repeating them. The investigations done by Dr. Vora are perfect. Full blood count, including neutrophil count, CRP, D-dimers, fibrinogen, serum ferritin, and IL-6 are obviously what we need to know. If the patient is clinically very well, if the saturations are being maintained, especially after a 6 or a 10-minute walk test, that is absolutely fine. But I would certainly repeat the investigations, especially the CRP, the inflammatory markers, D-dimers. I would repeat that, say in about another 4 or 5 days time. But I would not go for a CT scan if the saturation remains fine, if the D-dimer is within normal limits. CRP is a bit raised. Yes, we probably will, because this is a patient, oncology patient. I'm not sure whether the patient has had recent chemotherapy. Is the patient?
Yeah. It's on induction. Okay, I got the idea.
It's on induction. Well, in that case, the CRP has to be taken seriously. I would suggest another investigation here, especially for someone who's immunosuppressed or on current chemotherapy. I would do a PCT for this patient, procalcitonin. Because this is one investigation which will definitely differentiate between a bacterial infection or a viral infection, and rather the only investigation.
So Tarini and Dr. Mukul, just addition, CBC is normal today, normalized. Patient is in remission, but day 29. So today patient has not received any steroid, and yesterday patient has started having fever. Question is, do we continue steroid with this C-reactive protein? I have promised patient that I'll answer these questions to her at the end of this webinar. That's why, Tarini, I'm interested in knowing these answers. Otherwise, we can continue Tuesday also. Because we have we still have tocilizumab to be discussed.
That is very important, Amish and Parikh. Instead of rushing, I think it is better that we, give detailed answers to each of them and continue from Tuesday for the subsequent part. Over to you, Sahoo.
Right, sir. For this particular patient, in fact, Chetan or anybody who's dealing with oncology or leukemia patients, at this point of time today, what would you do? Should we start on favipiravir? I'll do procalcitonin tomorrow. But should we start on favipiravir? Should I continue steroids? These are the two questions which I want to ask.
Dr. Sweta Bansal spoke about she would like to continue on steroids for this patient. Dr. Chetan, would you restart? Would you continue steroids? First, point number one for this patient. Point number two, how frequently would you investigate such a patient? Is it every 3 days as people felt, or would you do it on symptoms deterioration or some new onset of symptoms?
So I would wait for a day and give the patient a benefit of doubt. And tomorrow, probably, if the CRP continues to climb, ferritin continues to climb, D-dimer worsens, then I would consider steroids. Based on D-dimer, I would also consider Lexane for this patient.
So basically, what I get from you is you repeat the inflammatory markers on day 2.
Yes.
Okay, so that's interesting. So you do it much in a shorter time. Can I have the chat box on this, Prashant? Anyone who's managing?
Say something?
Yeah, Roshni, please.
Since the CRP is rising and she has fever, we need to start empirical antibiotics after the cultures and procalcitonin, doing the chest X-ray, and also keep a watch for fungal infection.
Okay,
I mean, we're not dealing with one scenario. We have a background of a leukemia and so many other problems which can come in.
So if the procalcitonin is normal,
Roshni, do we admit this patient at this point of time?
I have a more basic question.
Can't admit.
Sorry.
No, it's okay. If the procalcitonin is normal, if the patient has fever because he's a leukemia patient and the chest X-ray is normal, are you suggesting we add antibiotics?
Chest X-ray has no meaning. We need to
understand. Has no meaning?
Has no meaning. You may not.
Okay.
If you're looking for background fungal and all, you may not pick up on X-ray. We need to think about other differentials also apart from.
Okay.
Can I ask a question? Can I ask a question?
Please.
When it comes to the patient management, if this patient has had induction chemotherapy, has been in remission, is the patient not on prophylactic antiviral, antifungal, and septrin, cotrimoxazole? Because that I thought was bare minimum. The patient should have been on acyclovir, should have been on some form of oral antifungal.
No, we don't use routine antifungals in ALL induction.
Do we not? Well, I think here we do.
The septrin is routinely used.
Septrin is for obviously for PCP management.
Yes.
Yeah, and then acyclovir. So you don't use routine antifungal. That's absolutely fine.
Antifungal, the recommendation normally is for AML infections. People do use it.
Fair enough.
For ALL, non-high risk people don't use it.
Fair enough. So the thing is, a procalcitonin obviously is a good marker for bacterial infection, but not for fungal infection. So what Dr. Pandey said is, I would take your point, but there are two more investigations I would do in these patients where the CRP is rising. I would do a serum galactomannan and a serum beta-D-glucan.
Oh, okay.
So
we are going towards fungus. Yeah, Chetan, please.
I would say that it is too early to investigate for a fungus. If the fever persists for a prolonged duration of time, then I would investigate for fungus.
Oh yeah. So I'm not saying do it now. I'm saying if the CRP is, if the inflammatory markers are rising and if the fever is persistent, then think of fungal if the procalcitonin is normal. We've not done the procalcitonin yet, so obviously it's early days. If you
I assume procalcitonin is normal. I asked the same question to Dr.
Okay, so if the procalcitonin is normal but the fever continues and if the inflammatory markers continue to rise, then I would think of a fungal infection.
Okay, so beyond 3 to 4 days, if the fever continues, probably will all look at fungus. That's what Dr. Chetan also suggested. I hope, Roshni, that answers. Yeah.
Blood culture and antibiotics, I would start.
That's done. Okay, blood culture would be given.
The moment patient has fever, the first investigation to be sent is blood culture. So I'm assuming that we've done all the septic screen, including urine and sputum, and blood culture.
Can I ask a different question, Dr. Nandita? Maybe the last before, because we are out of time. I wanted some ICU questions to have. Just two questions, Dr. Nandita. Do you routinely give antibiotics? Let's say it's a non-leukemic patient. I just put this spectrum differently. Do you give antibiotics to all your patients who have fever, whose procalcitonin is normal on a COVID?
No. So we are guided by of course, we are guided by the patient, each individual patient, but we keep a close eye on the PCT. And suppose even if we've started antibiotics and the PCT comes to normal, then we stop the antibiotics. So that's what we do, because the chances of super infection, and with this COVID, we've seen a lot of super infections. I think Mukul will agree with me with fungal infections and really this. So we get guided by the PCT.
I brought this out because I brought this out. I wanted to put it forward where leukemia, we are a little scared. But most of the do start antibiotics irrespective of leukemia and non-leukemia. I wanted to bring this out because I was speaking to my friends in the US. They do the same thing. They were against antibiotics at totally if a procalcitonin is normal. That's what they practice.
Can I just sort of make a small point? When the question was asked to Dr. Nandita, I mean, unfortunately, in UK, it is the microbiologist who decides whether to start antibiotics or not. So unfortunately, Dr. Nandita's hand would be tied. So before she starts an antibiotic, her first call would be to the microbiologist.
Dr. Parikh, I think we will be out of time. I'll ask one question, Dr. Nandita, which I read in the guidelines for ICD. Dr. Nandita, there is written in COVID ICU care, dopamine is to be avoided.
So we've not been using dopamine for a long time because we have stopped. In fact, even the renal units, I think, very rarely possibly use it. I don't remember the last time I have used dopamine. It's for many years we've not used. What we use generally, if there is any septic patients or anything, is noradrenaline.
Norepinephrine,
in case of card, yes, that's what we use. And if it goes too high, then we add vasopressin at times, but we don't use dopamine. So we don't do, sorry.
Okay, I brought this out because in India, a lot of dopamine is used, and if we go to guidelines in the US for ICU care, they specifically pointed out for dopamine is not to be used. I really just wanted to bring this question out. And last question to Dr. Nandita, I could not involve you more in the ICU.
No problems. No.
Would you recommend a ventilation in a COVID patient? Because the idea is ventilate late and avoid ventilation because. Could you answer that? And then I think I will hand over to Dr. Purvish and Dr. Amish.
Okay. So this is one of the most difficult questions all over the world.
Your voice is breaking, or I'm not able
Can you hear me? Can you hear me?
Yeah, we can hear you. Please go ahead.
So this is one of the most difficult questions all over the world. And we are, even with the first wave, we were thinking, did we ventilate too early? And therefore there were deaths. Next time we are thinking of whether, we are ventilating too late or something. So there are various criteria. First of all, we are very strict as to who is to be admitted and who is not to be admitted. And then depends on each individual patient. So we are discussing it. It's a big topic of this.
Can we come to ventilation part, because we are just running short?
Yeah. So the ventilation, if of course it depends on the patient's age and the symptoms as well. And suppose if we've tried them on non-invasive, so usually they go for non-invasive ventilation first, or high flow oxygen, and then if suppose a patient has got very high tidal volumes on the NIV, or if the patient has got sudden severe deterioration, like the oxygen saturations have gone and is very symptomatic, then we go for ventilation. But it is decided first. We decide together whether this patient is for ventilation or not. And
so, Purvish or Amish sir, you can take on. I think a lot of things are left for the next meetings.
Yes, thank you so much, Dr. Sahoo. Amish, I hand over for your comments. Amish, are you there?
Thank you so much. I think we should continue next time. We can take next time, if everybody, those who are present here, there are a lot of questions about CT value. So maybe we can complete the discussion on tocilizumab and then take on CT value. These two would be very important because every
Amish, we should have a discussion on CT scan and X-ray. Yes, CT scan for all or CT versus X-ray. That discussion should be there in the next meeting.
Right. Also, Dr. Rajeshwar had asked a question about bevacizumab. So bevacizumab also we will take up next time. There are lots of questions, lots of unanswered questions in the chat and Q&A, but we are run out of time this time. Thank you very much, everybody, especially all the faculty, as well as the people who, asked a lot of questions, gave their comments on their valuable experience. And we hope to see you again on Tuesday, 27th April at 7:30 p.m. sharp. Thank you very much. Good night. Stay safe and stay happy.